I think if everyone's ready, we'll get started. Good afternoon. My name is Erica Soboleski, and I'm the medical director. And on behalf of Summit County Public Health, I would like to welcome you to our syphilis, congenital syphilis, and PrEP educational event. Hopefully our first annual of the sort. I have a special thanks and recognition to Brooke Simonin and Kayla Petranek for the many months of planning that went into this important event. A few important announcements before we begin. Please note the restrooms are located to the right as you exit the doors and through the glass doors by the front welcome desk. The Wi-Fi password is located on the wall should you need to connect. This meeting is also being live streamed and recorded, so please silence your cell phones and take any necessary calls in the hallway, please. Additionally, we'd ask that you please complete the survey via the QR code on the front of your boxes. That'll also be emailed to you at the conclusion of this event. Along with, if you're applying for CME, there will be another QR code and registration that will be required for that. Again, that will all come in email at the conclusion of this event. We have two presenters with us today. We have Drs. Joan Duggan and Tommy Champus. Over the past few years, there have been a significant rise in congenital syphilis cases. In 2021, the state of Ohio had 49 confirmed CS cases. Our region, which includes Summit, Portage, Mahoning, Trumbull, and Columbia County, had 2 of those. In 2022, the case count rose to 93 confirmed cases, 7 of which were within our region. The rise in cases shows how increased education about congenital syphilis is needed within our community. To help with this effort, we have Dr. Joan Duggan from the University of Toledo to discuss the diagnostic and treatment updates of syphilis and congenital syphilis. Dr. Duggan is an infectious disease specialist with special interest in syphilis and HIV. She is also the medical coordinator for the Ohio Syphilis and Pregnancy Warm Line, which is a free consultative service that provides practicing clinicians within Ohio with prompt expert consultation on questions involving individuals who are pregnant, breastfeeding, or a pregnancy potential. Dr. Duggan's presentation is eligible for CME for physicians, nurse practitioners, and RNs, and again, that QR code will be emailed to you at the conclusion of this event. Due to the high incidence of co-infection of HIV and syphilis, it's also important to discuss the availability of PrEP, or pre-exposure prophylaxis, with at-risk patients. To discuss this topic, we have Tommy Champus, PharmD, and Senior Medical Scientist with Gilead. You're in the back. He disclosed his relationship with Gilead, but will speak today with non-promotional slides that are intended to be for education for all of us. There will be time at the end of each presentation to discuss any questions, and for those joining virtually, please put any questions into the Q&A, and they will be presented to our presenters. Please join me in welcoming Dr. Duggan.
Okay, thank you all so much for having me here today to go over syphilis, HIV, STIs, PrEP, PEP, DoxyPEP. Yeah, no, I'm not getting to all that, right? Okay, so the way I wanted to kind of tackle this is to focus, kind of hit on a little bit of those topics, but mostly focusing on diagnosing syphilis, okay, and going over the tests that are ordered. And why is that? Because I think if people get more familiarity with the tests, they'll actually order them more. Seeing all that verbiage, seeing the results won't be concerning to them, and they'll actually just check that button all the time for RPR, VDRL, or the other tests that are available for syphilis. They'll just get ordered, and that's the first part of tackling congenital syphilis, HIV, STIs. So real quick, let me just see if I can get my pointer on here. My pointer. Is it a pointer? Yes. Okay. So we've been seeing a lot of increases in cases of syphilis over the last 6 to 8 years. And we're seeing a 200-fold increase in cases of syphilis among newborns. And to give you an idea about this, in my part of the state, the Toledo-Lucas County Health Department actually had a whole bunch of billboards about rising rates of syphilis. Syphilis is serious, things like that. And I got a lot of questions from docs saying, wait a minute, didn't we cure syphilis? The answer is no, we cured smallpox. Pretty close. Not the same. Okay, now here's some of the numbers that we have for syphilis in Ohio. So this is 2022. So 93 total cases of congenital syphilis in the state of Ohio in 2022. 35% were in Columbus. That was the highest in the state. There were 8 stillbirths statewide, and there were 4 infants that were born alive and then died with diagnosis of congenital syphilis. Okay. And I got these from Mark Paulzak from ODH, who is our congenital syphilis specialist. And as of October 23rd, 2022, so last week, there were 55 total syphilis, congenital syphilis cases in the state of Ohio, CS. By county, Franklin 17, Cuyahoga 10, Hamilton 9, 4 stillbirths already statewide. And I took this quote from Mark because I think it's really important. Mark said, I started my career in 1993 and we have never had this many cases of congenital syphilis, and we have never had this many fetal deaths attributed to congenital syphilis as we've had. And 2022 was the worst year for this in 30 years. That is absolutely awful and a horrifying indictment of our public health system that we're looking at these numbers going the wrong way. So it's not just us, okay? This is nationwide. So this is from the National HIV Curriculum, and these are congenital cases of syphilis, and just the numbers are going up, okay? And this is a nationwide thing. Our experience in Ohio is a reflection of this. And so in order to combat this, we need to start increasing our awareness, first of all, that syphilis rates are rising. So if anybody in the state of Ohio asks me to give a talk, I will drive down to give a talk on syphilis to raise awareness of this, because this is huge. And we've got to increase routine testing and surveillance for syphilis for all ages, okay? We're getting cases of syphilis in people under 18, but we're not getting our pediatricians to check the box to order the test. And that's the first step in making the diagnosis, right? So the increases that we're seeing in these diagnosed cases of syphilis, remember, like all communicable diseases, they represent the tip of the iceberg for the actual prevalence and incidence. So in order to get people more comfortable with talking about syphilis, thinking about syphilis, moving it up into their diagnostic thought processes and ordering the test, I want to take a quick review of the transmission, clinical manifestations, and the diagnosis, and skip a little bit over treatment. Now, the state of Ohio, Ohio Department of Public Health had piloted a syphilis warm line where you could, using a QR code, you can get in, and it's on the website, and ask a question for infectious disease docs, high-risk maternal fetal medicine about syphilis, if you can't get a hold of somebody in your public health department. So we're always there as a resource for you. All right, now so it might be a little bit hard to see from the back, but this was a limerick that was written by a Harvard medical student in the right around World War I, so before 1920. And it actually is a pretty good summary of a lot of the stages and manifestations of syphilis. So instead of studying, he was writing this limerick, but that's Harvard. Okay, here it goes. There was a young man from Back Bay who thought syphilis just went away. He thought that a chancre was merely a canker that healed in a week and a day. But now he's got acne vulgaris, or whatever they call it in Paris, on his hands and is spread from his heat to his head, and his friends want to know where his hair is. But there's more to his terrible plight. His pupils won't close in the light. His heart is cavorting, his wife is aborting, and he squints through his gum barrel sights. Arthralgia cuts into his slumber. His aorta is in need of a plumber, and now he has tabies and saber-shin babies, while of gum as he has quite a number. He's been treated in every known way, but his spirochetes grow day by day. He's developed paresis, has long talks with Jesus, and thinks he's the queen of the May. Okay, so this is, in a nutshell, syphilis. So we're going to break this down a little bit. Okay, so primary syphilis The incubation period is 2 to 3 weeks, but the range for us for treatment for this is 10 to 90 days. And efficacy of transmission with primary syphilis per episode of sexual contact is about 30%. Now, during this stage, first thing you get is lymphohematogenous dissemination, and the chancre may develop, but it may not, or it may be very, very, very subtle, and this will usually heal spontaneously the week and the day. It's usually gone by 2 weeks. And significantly, a huge number of people with syphilis will not report the presence of a chancre, and because they're painless, a lot of women, and internal, a lot of women won't notice, okay? Now, for secondary syphilis, untreated, natural history, about 25% of people are going to go on to develop secondary syphilis. And rash is the most characteristic finding, and this can take almost any form. So this, this part, now he's got acne vulgaris, or whatever they call it in Paris, on his hands that has spread from his heat to his head, and his friends want to know where his hair is. All right. A rash on the hands and the feet is one of only a handful of infections, Rocky Mountain spotted fever, or things like that, that are associated with syphilis, okay? But hair loss, alopecia, classic manifestation of syphilis. And the rash for syphilis can look like anything except for blisters. So if you ever look at somebody's old diploma from before the Vietnam War, a doc's diploma for dermatology, it will actually say specialty of dermatology and syphilology, because any type of rash can be a syphilis rash for secondary syphilis, okay? And the relapse rate that can occur in patients with secondary syphilis after it passes for within a few weeks, months, is 25%. And you're contagious during the secondary syphilis rate. Now, rash, again, is the most common finding that you've got, but you can also see constitutional symptoms like fever, sore throat, etc. You can see elevated liver enzymes, neurologic involvement, and this is the time when you can also see ocular and otic syphilis, okay? And remember, if you have any eye involvement with syphilis, even in the secondary stage, we treat that like neurosyphilis, okay? Now, latent syphilis, early is defined as less than 12 months and late is defined as greater than 12 months after you've had a negative test, right? So if you're doing your testing, and you got an RPR, you go back and you check when the last negative was, all right? So if you got a 1 to 64 RPR and your last one was negative 6 months ago, you are early latent if you're asymptomatic. If your last syphilis test was never, can't find it, more than a year ago, by definition, it's latent, all right? And then you have to do a clinical assessment to make sure there's nothing else going on, okay? Neurosyphilis, otic, ocular, tabes dorsalis, including pupils that don't react, dementia, altered mental status. These are all the huge things that are in the literature from 100 years ago. Syphilis in pregnancy. So stillbirth is common in the second and third trimester, but you can also see preterm labor and impaired growth. And if untreated during pregnancy, if we don't pick it up, it can result in congenital syphilis. Now, it's preventable if you give treatment during pregnancy before the last month and you use a penicillin-based regime, okay? So real quick, so I know that was really, really dense. That was a lot of material. The slides will be available to go over later. But that's kind of a quick background on syphilis. I mean, that's there's an expression, if you know syphilis, you know medicine. And that was all of that in one slide. So that's a lot of stuff. But just to kind of move it down a little bit into a quicker slide. So if you get infected with syphilis, you can develop primary syphilis. That's the chancre, okay? It's not a canker, it's a chancre. And a significant number of people develop secondary syphilis. After secondary syphilis, you move into the stage called latent. It's clinically silent, okay? This is really key. Watch this. This goes back like this. And again, this comes from the National HIV curriculum. Primary syphilis and secondary syphilis are the stages that are contagious. If you have latent syphilis and you've never been treated and you picked up syphilis during the Korean War, yep, you can revert back to if you've never been treated, an infectious stage in secondary syphilis, okay? Then tertiary syphilis, and a certain number of people probably clear this themselves and resolve. But again, we're not entirely sure what's going on there. And part of that is because we don't have we can't grow this in the test tube, and we don't have like a good mouse model for this, so it's hard to study. All right. Now I want to take 1 second to talk about latent syphilis. So latent syphilis is the stage of syphilis that's characterized by the persistence of these organisms in the body without causing any signs or symptoms. So it's the clinically silent stage, all right? It's asymptomatic, again, divided into early and late, and that would depend on when your last test was. If your last test was negative within the last year, it's early. If you never had one or it's been more than a year, it's latent, okay? All right, now, transmission, all right? Sexual contact during primary and secondary stages are the main ways we transmit syphilis, okay? If you're asymptomatic, it's not transmissible. So if you've moved into latent, it's no longer transmissible, but you always have the potential to relapse. That's why we try to treat everybody who has syphilis, okay? And we're familiar with these concepts, like latent tuberculosis infection, a positive PPD. You can always relapse and develop active pulmonary tuberculosis. That's why we like to get people treated. This is very different, though, than pregnancy, okay? And this is huge. Transmission to the fetus in pregnancy can occur during any stage of syphilis and any trimester, okay? So if you had syphilis 7 years ago and you got treated, maybe partially treated, maybe didn't have a good response, and you have latent syphilis, you can transmit to the fetus, okay? Now, the highest risk of transmitting to the fetus is when you get infected with syphilis in the 3rd trimester. That's really the highest, okay? Very, very rarely are other forms of transmission of syphilis seen. All right. Now, how do we diagnose syphilis? Okay, so remember, I wanted to give you guys a little bit of background on syphilis, talk a little bit about transmission, and then move into diagnosis to get you really comfortable with encouraging people to order the test and having an idea what you're looking at when you see the different types of results and what the next steps are. Because unless we get really, really comfortable talking about syphilis, thinking about syphilis, and ordering the right tests for it, we will never make headway on this public health emergency, okay? So we can't, one of the big problems is we can't grow syphilis in a test tube. Okay, we can't culture. We're still using blood tests to figure it out. And they are working very, very hard. There was a recent article in Science Magazine. They think they've got a live animal model that's going to be available pretty soon in a rabbit for research, but it's not yet ready to go prime time on. You cannot see the organism with an ordinary microscope. It requires a really, really special microscope, and you have to change this little thing in the microscope, and that little thing that we have to put on this little filter costs like $20,000. So most places don't have them just lying around in their micro lab, okay? You can get antigen screening, you can do certain kinds of silver stains, but none of these methods are really, really good. Our mainstay for the diagnosis of syphilis remains good old-fashioned blood tests. And yes, this should probably be a horror to everybody, but the current tests we're using, if Dr. Wasserman walked in 1907, after he published his seminal paper in 1906 on this, he'd recognize what we are doing, right? Okay, so we're working really hard on getting better testing here, but that day is not today. So there are 2 main types of tests that we use: treponemal antibody tests and non-treponemal non-specific antibody tests. And we use these tests together to make a diagnosis, okay? All right, so I'm gonna real quick talk about non-treponemal tests, then treponemal tests, and show you how we're putting them together, okay? All right, non-treponemal tests. This tests the serum from an infected patient for this compound that gets formed. It's called a reagent antibody. This bizarre cardiolipin compound that gets formed when people are infected, okay? It's nonspecific. It's looking for this special antigen. Sometimes, though, the test is triggered when you have another nonspecific antigen like a lupus anticoagulant or something like that, but you're looking for this nonspecific thing. And so they're nonspecific. They're looking for a surrogate marker for infection, not the organism itself. So this is not a definitive test. It's got a lot of cross-reactivity. But we use this all the time. Why is that? Because it is low cost, fast, and easy to do, and that makes it a great screening test because we can do huge amounts quickly for people, okay? And then sort out the positives when we get them, all right? So in these non-treponemal tests, the main two names most of you will recognize are the RPR and VDRL. Okay, those are the names most people will recognize for syphilis testing. And these are non-specific, okay? And they measure both IgG and IgM that's formed to this compound. And we report it as a titer, all right? Because a titer is a reflection of disease in true positive cases. A titer is a reflection of disease, okay? Now, at the lower numbers, 1 to 1, 1 to 2, 1 to 4, maybe 1 to 8, it's possible to have a false positive. You get up to these higher titers, like 1 to 512, they're not false positives, okay? All right, and what we do is we take the serum and then we dilute it and put it into each well, and we watch when the well pops up positive to give us our titer. And titers will naturally decline over time. Treatment does speed up the titer fall. So sometimes you can have people who were infected 50 years ago, never appropriately treated, who have a negative titer just because they've lost their antibody over time. They're still infected. All right, now, for everybody that this is probably review for most people, but just, you know, in case it isn't for some people, let me just talk to you a second about when we talk about titers, okay? So we take the patient's sample here and we dilute it 50% with saline, and that's a 1-to-1 titer, okay? 50% my serum, 50% saline. I then take 50% of that out and move it over here, and that's a 1-to-2 titer. I keep diluting it, and then when I see when it pops up, where it pops up positive tells me the titer for the person, how much of this antibody they're producing, okay? So if you have it, and we look at treatment response based on titer changes. So you often hear people talk about a 4-fold increase or a 2-fold increase or an 8-fold increase. This is what it actually means, okay? So if you had a person who had a 1-to-16 titer for an RPR and they had a 2-fold increase, they go up just one set of tube dilutions to 1-to-32. 16 times 2 is 32. If they have a 4-fold increase, they're going to move up 2 slots, but 8 times 4 is 32. That's a 4-fold increase, okay? Same thing going down. A 2-fold decrease means they go from 1-to-32 to 1-to-16, okay? You can probably tell now when I'm talking to you that a lot of times this is actually, because it's only moving one tube back and forth, a 2-fold decrease in titer can sometimes just be lab error. That's why we say that, okay? That's why we make you repeat it. And it might not represent a true fall, okay? Because they're right next to each other on the machine, okay? All right. Now, any questions? I know that was really, really, really dense material. I know that because the medical students complain. But you all don't have a test, so you're all lucky. Any questions at all on that so far? Just to stop, I know there was a huge amount of stuff. Any questions? So for treponemal tests, so the first ones I went over was RPR and VDRLs. Those are non-treponemal tests. The second tests are treponemal tests. These are specific treponemal tests. These actually measure syphilis itself, okay? There's a whole bunch of different names for these things, all right? FTAs, TPPAs, EIAs, CIAs, and there's one point of care test that we've got, and this is like this is going to be like the holy grail for this, is getting a really good, effective HIV point of care test out there. That's actually a specific treponemal test, specific, not a non-specific. And it's the SHC, Syphilis Health Check. It's got a sensitivity and a specificity. It's not as good as we'd like. The sensitivity is only about 71%. So as a safety net testing, you miss a lot of people. Okay. All right, so these treponema tests, these actually take a look at the antibodies that are directed against T. pallidum itself, not some weird compound that's made when it interacts with the tissues, but the organism itself, all right? And these are qualitative tests. The first ones are quantitative tests. We give you a titer to it. And the titer goes up, the titer goes down, and treatment makes it change, and we watch that. These tests, the specific tests, they're reported as positive or negative, and once positive, they are positive for life, okay? This is why we don't use, and these are a little harder to run too, that's why we don't usually use these as a screening test in the traditional algorithm. But we flipped that on its head recently, and we're actually starting now to screen people with this, okay? All right, so we take a look at some of these tests. Some of these are really, really, really good. Like if you have secondary syphilis, almost everything picks it up. Almost everything picks it up, okay? It's just when you have primary syphilis, when you're contagious, when as public health people, we'd like to find you and get you treated. So when you really need this test to work, your VDRL and RPR let you down a little bit, okay? The sensitivity for VDRL during primary syphilis, only about 78%, RPR about 68, about 86%. And y'all know that when you have a person who has primary syphilis, the test can be negative, right? Unfortunately, just when we really need it, it'll be negative, okay? All right. So looking at these two tests specifically, just the VDRL and the RPR, good old-fashioned traditional starting tests. In primary syphilis, not as sensitive as we like, very sensitive in secondary syphilis, and pretty good in latent and late or tertiary syphilis. Okay. Our non-treponemal tests our treponemal tests, our specific ones, our FTAs, aren't a ton better during primary syphilis, the traditional ones, but they're all, again, really good during secondary and latent syphilis. Okay, so traditionally, when we have somebody that comes into CU and you're doing screening for STIs, STDs, you're doing your workup for PrEP, or you're doing a post-exposure prophylaxis workup, one of the things you'll order is a test for syphilis, right? And you're going to start often, previously, with a traditional RPR or VDRL, okay? And if it's negative, you say no evidence of syphilis. Problem is, we know that that's going to miss maybe 15% of primary syphilis. So our good old-fashioned tests aren't really as good as we want them to be. That makes Dr. Wasserman sad, but I'm sure he's probably thinking, what, you guys haven't done any better since 1907? At least that's what I'd be thinking if I were him sitting in the room. And anyway, if that's positive, we then confirm it with a specific treponemal test, an FTA or TPPA, and it's positive, it's syphilis. Okay, all right. So when you do this traditional algorithm screen, if your RPR is negative and your FTA is negative, we say you have no syphilis, but really the answer is you have no syphilis or really, really early syphilis. If your RPR is positive and your FTA is positive, you have syphilis. Could be in the past, could be active now, you have syphilis. Could be improved, could be getting better, depends on what that titer is. But syphilis has been in the picture, okay? If your RPR is positive and your FTA is negative, that's your classic false positive. And that's what, the OB-GYNs often send them these to you. You got a positive RPR, negative FTA. They just want you to weigh in on it to make sure it's okay. That's your classic false positive. And then if you've had treated syphilis, or you have a related, a cousin to the treponema pallidum, if it's treated appropriately, you'll have a negative RPR and you'll have a positive FTA. You'll have a positive treponemal screen for syphilis. Okay. Now, we've made a little bit of headway in treponemal testing, okay? And we've got some newer tests that are ELISAs, okay? Enzyme-linked immunoglobulin assays that are actually pretty darn sensitive. They say 100% on the national HIV curriculum. It's really like 99. But these new ELISAs are really, really, really good at picking up primary syphilis. They're really, really good at picking up secondary and latent syphilis. They are really, really good, okay? And so these newer tests, they're automated. Once they're positive, they're always positive for life. Okay, they can cross-react with other treponemal infections. You can't use them for testing CSF, but it's what we want everybody to start using, okay? And that's because of a big study that was published in 2008 in MMWR that shows that if we use this test, we're going to pick up maybe up to 5% of early cases of syphilis in a large, this was in a New York City STI clinic, over a year, that would otherwise be missed. So in real life, when they did this study, when they used these newer tests to screen for syphilis, these newer blood tests, they were picking up like 4,000 cases out of 100,000 of early syphilis that they would have missed using the old-fashioned method, right? And this is the kind of thing that keeps driving the epidemic. Okay, so that's the whole background for the old-fashioned tests, the old way to do it. This is the newer way to do it. This is what we want to make sure most people around the, not most people, everybody around the state is doing, because you're going to pick up more early positive tests. You're also going to pick up a lot more false positives and other things. It'll drive you a little bit crazier, but it's a bigger, better net to cast. And we need to do this now because we have way too much. We are in the middle of a syphilis epidemic. All right, so these newer tests, these ELISAs, if they're negative, they're so good picking up primary syphilis that if they're negative, we say it's negative. All right, now if you have somebody that your DIS guys call you up and say, you know, they've been named on look back in the last 90 days, you just treat them anyway, right? Okay. But if you're doing your routine screening for PrEP and things like that, and you start with these ELISAs, if they're negative, you can feel pretty good that there's no syphilis that you have to worry about, okay, for that visit, okay? If they're positive, we then order one of our old-fashioned RPRs or VDRLs to try to sort it out. And if it's positive, okay, so if the treponemal test, this newer one, and an old-fashioned one are positive, it's syphilis. And then we can look at the titer to see what's going on and also the treatment history. If it's negative on this on the old-fashioned RPR VDRL, we go ahead and get an FTA or a PPA to be the tiebreaker for this. Okay, and if it's positive, we say yeah, it's syphilis, and if it's negative, we say it's unlikely. Okay, so this is flipping the way we do syphilis screening. Okay, not RPR to FTA anymore, not VDRL to FTA anymore, or TPPA. It's a real specific ELISA test, and if positive, then it's your old-fashioned traditional algorithm on top of that to follow that, okay? All right, so again, just take a real quick look at it. If with this newer test it's negative, you should feel pretty comfortable there's no syphilis, okay? With a positive RPR or VDRL, with positive ELISA, we then do the screening for the old-fashioned RPR or VDRL, and if it's positive, syphilis, okay? And the titer will tell you where you're at in addition to the treatment history and what you got to do. If it's negative, so you've got one positive, one negative, you use the old-fashioned, a different type of traditional treponemal antibody test as your tiebreaker. And if it's positive, it's syphilis, and if it's negative, syphilis is unlikely, okay? Unlikely. All right, now, just to throw something in real quick, when you're doing your testing for syphilis, also don't forget to do your HIV testing, and don't forget to do your 3-site screening for STIs, okay? So, we screen for syphilis in pregnancy for everybody, all right? Universal screening recommended. We can also rescreen at the 28 and 32 week and at labor or delivery. We're really recommending you to screen twice during pregnancy. Just make it, don't do it risk-based, just do it, okay? Because remember, syphilis can affect the fetus regardless of trimester or stage of infection. But also, please don't forget to screen for HIV. And remember that while syphilis is the great imitator, The findings of syphilis in pregnancy aren't changed by being pregnant. It looks just, so as you all know, sometimes when you're pregnant, like you can have a presentation of appendicitis that's different. It can be on the left side or it can be higher up. Not with syphilis. Syphilis looks in pregnancy just like it does if you're not pregnant. All right, so real quick, we've got some stuff here in the back on 3-site testing, including a QRL code, because we also want to be emphasizing that kind of like status neutral, we've got to think of this as one large item, not just syphilis testing. We can't have just a division of syphilis and HIV and, something else. This is one large group. Yes?
Question.
Yes.
Going back a slide.
Going back a slide.
Is that for a person who's never tested reactive for syphilis? Or is that for a person who's also tested reactive for syphilis before?
Am I at the slide?
Yes. Perfect.
That one? Okay. What was your question again?
So if a person's had syphilis in the past, would they still take the EIA?
Yep.
And would you still refer down to the titers?
Yep.
The new increase of the new infection versus baseline of always having a 1-to-1 or whatever that may be for that person if they never return back to non-reactive?
Yep. So if you have syphilis and it's been treated successfully in the past and your titer is down to 0 and you're doing great, this is what it should look like on the test. Positive ELISA, negative RPR, positive TPPA, but you've got the history that has been treated. That's why the treatment history when you're using these is so very, very important. That's what that test will look like, and that's what the algorithm will look like with treatment history.
So they will always return to non-reactive up their titer to like a 1-to-1 and maintain a 1-to-1 and still be non-reactive because they don't have a 2 to 4-fold increase.
Oh yeah, so 1-to-1 is the dreaded serofast, right? And it can go all the way up to 1-to-16 and still be serofast. And I think to myself that serofast is the reason why I've not yet been replaced by ChatGPT. So, because you still have to ask, like an opinion on it, and you have to kind of kind of make it the thing. So that is correct. That's I didn't put anything like that in because this was so dense already. I skipped over that what serofast is, but that's just when you keep that low level RPR forever, doesn't change. You're not infectious. There's no CNS involvement, but it never quite goes back to 0. We don't know what's going on with that exactly, and that's called serofast, where your titer is always like 1-to-1, 1-to-2. And then we watch for going 4-fold higher for possible reinfection. Great questions. All right, 3-site testing, what is it? So this refers to screening with nucleic acid amplification tests, the new NATs, for the following areas for chlamydia and GC: oropharynx, anus rectum, urethra, endocervical. And why do we do it? Because those traditional screening tests that we do for chlamydia and gonorrhea miss a whole bunch of stuff. So there was a great study that showed that in one STI clinic, and this was in Boston, more than half of chlamydia and 3/4 of gonorrhea weren't in were at non-urethral sites, and they're missed if all you do is just get a urine gnat. You're missing like 2/3 of them, okay? And if you're just doing urine on women, you're going to miss at least 10% of infections, okay? So 3-site screening compared to traditional screening. In one study, 99 HIV positive men were enrolled, and this was huge. Nearly 99% of the gonorrhea and chlamydia tests that they had were missed when they were only using urine. 99.5%. That's huge. So just remember, traditional screening for STIs with one site is not effective. If you think you're screening for STIs in an STI clinic and you're not getting newer ELISA tests for screening for syphilis, and you're not doing 3-site testing, and you're not doing a 4th-gen HIV, you're going to miss stuff, okay? It's just a picture of that. All right. And who do we test for this? Well, if you have HIV, first evaluation, then at least annually, MSM at least annually, and if you're doing PrEP, according to the government guidelines, CDC every 3 to 6 months. All right. Okay, so why did I make a quick detour onto HIV and STI testing when let's talk about syphilis? Synergy. Okay, synergy. These are synergistic. According to the CDC, people who have an STI have an increased risk of acquiring HIV. People with HIV are more likely to shed HIV when they have urethritis or a genital ulcer. And if you look at one study that was done in Florida, 22% of HIV negative men who were diagnosed with syphilis in 2003 by follow-up in 2011 were HIV positive. Okay, and remember, we've got the tools to stop this from happening. We've got to start thinking about these infections like sentinel events. They've broken through our public health safety nets. I'll calm down. Okay. All right. Now, this is a really, really, really dense slide. Unless you're doing OB-GYN or working in the clinic, it's a lot in here. But screening and diagnosis of syphilis in pregnant women. I just want to point out that we often recommend, actually routinely recommend screening twice during pregnancy. Okay. This one talks about it being risk-based. We're trying to get away from risk-based screening and just make it part of the routine protocol. Because we know from every study that's been done that when we make things risk-based and not routine, we miss stuff. Okay? All right. Yeah. Now, false positive syphilis tests are definitely more common in pregnant than pregnant women. And when you use that reverse algorithm, it doesn't help that at all. But you got to do the test, and then we have the tools to evaluate a false positive and determine that it's a false positive with additional testing. Okay, and so that should not be a problem. This is a treatment slide that'll be in the slide deck, and it's very dense, but it's there for availability if people want to look at it from the Pediatric Journal of 2022. Future diagnostic studies. So ideally, it'd be great if we had something that was really, really, really accurate and rapid and worked really, really well. And an ideal would be a point of care test. And we're getting closer. There's one rapid HIV and syphilis combo test that actually is 99.5% specific for HIV and 95% sensitive for syphilis. And it's actually, hopefully there will be more tests like this coming on the market, but we are getting there, right? And these point of care tests, it's what we're going to need to end these epidemics. Hepatitis C, HIV, syphilis are excellent, good point of care tests. So we can get testing done while the patient's there and get them linked and get them treated. Okay, so I had a quick test, question I just wanted to walk through. And so I'm going to read the question, and then I'll just hum real quick the theme to Jeopardy. And you just look at the answer, and then I'll go over it with you just to see where you're at, okay? Don't share anything. This is for you. So if you have a pen, just write down the test. All right. Okay, 34-year-old woman is screened for syphilis. She has a positive first screen for syphilis, okay? The laboratory reports an RPR, and they tell you it's non-reactive. Everything else is negative. She's totally asymptomatic, been with the same partner for the last 3 years, no history of any STDs. She's asymptomatic, everything is normal. What should you order next for this woman? Should you repeat both of those two tests? Should you send an alternative non-treponemal test, an alternative treponemal test, or no further workup? All right. So A, B, C, D. Just think about an answer. Get it in your head. Don't have to share with anybody. This is from the National HIV Curriculum. Okay, here's the answer, all right? The answer was to send an alternative treponemal test, all right? So this is the algorithm. This is just the algorithm in motion, right? The ELISA's positive. The RPR is negative. What do? You send the third test for the tiebreaker, okay? And that's a treponemal test. It's a specific one, okay? And so that was the answer, all right? And then on the slide set, there's a real dense, this is from the National HIV Curriculum, real dense explanation of that. But that, in a nutshell, was an overview of syphilis and diagnostic testing. And hopefully, and remember, most of these tests are automated. If you order it, the lab will run it through an algorithm. So if it's positive, you don't have to order extra tests, they'll do it for you, okay? But the most important thing is that you're ordering these tests and you're thinking about it, right? So the patient comes into clinic for PrEP and it's December and they've got this rash, and I've literally had people tell me this, it's, I think I have poison ivy or just irritated skin, and I'm like, poison ivy in December in Toledo, Ohio? What you been doing? Did you travel? No. Did you dig out the snow? No. Okay, so you got to get thinking about this, all right? And that's some background for when you're thinking about it. But the most important thing is order these tests. Just order them. And don't use risk-based assessments. Just order them on everybody, okay? All right, any questions? Now, I know that was a ton of stuff. Yes?
So, I work for a pregnancy resource center, but, with, testing for urine, if we send it out to the lab, it comes back and is, negative or positive, should we just automatically refer to the PCP or the health department, or should we just for the positive test only?
So I think every county does it differently. If you have a pregnant woman who's positive for a urine test for chlamydia or gonorrhea, and all you did was urine, remember, you're going to miss at least 10% of STIs in other locations. In our area, that would go to the provider, and we don't do DIS for tracing for chlamydia and gonorrhea, I believe. So that would go to the provider that ordered the test. And hopefully that would make it to the OB-GYN or the nurse midwife or whoever was had prescriptive authority for that. What normally happens when you get a positive test in your area?
We normally just refer them to their primary care.
Okay, I mean, as long as you've handed it off to a person with prescriptive authority, that's what has to happen. And then ideally a follow-up, the patient. Any other questions at all? I know this is a ton of stuff. Yes?
I'm not a doctor, but do most places like Planned Parenthood or here at their clinic do the 3-site testing? Is that very common? Because I haven't heard it being common.
So we are doing this in Lucas County in our public health department STI clinic, and we do it in our Ryan White clinic. And pretty soon we're going to be adding anal pap smears to that too, based on the anchor study. We're piloting that out too. That is a great question. Let me ask the audience, so for those of you that are working in your health department and STI clinics, how many people are doing 3-site testing? Like, is it a lot? Okay. It's what we really, really want people moving towards. Really, really want. There was a recent paper, though, that came out on this, and it was from the Netherlands, and they just presented it at ID Week. And it hasn't, it's either going to be released for, I think it's already out in publication. I don't think it was a preprint. That also said that instead of doing routine testing for everybody for 3-site, you actually don't miss a lot of people if you hand them the screening kits and say, you need to screen yourself. Self-collected works great. There's great data on that from University of Washington. Screen yourself in the areas where you are sexually active. So if you never have rectal sex, you don't have to do that. And actually, they found that they didn't miss a lot of STIs doing that, and it was cost effective because you weren't doing 3-site screenings when you didn't have to do it. So it was a cost-effective analysis from the Netherlands, I'm pretty sure. Any other questions? Yes?
I have a question.
So unfortunately, in an age when unfortunately penicillin is a shortage,
Yes.
we have people receiving 6, 7 injections of penicillin. Is there a time frame when enough is enough, or do we always have to start over?
That is a great question, especially since we are having a problem with bicillin. So I don't know if anybody knew this, but there was only one plant that was making bicillin, and that's why we have this shortage. And it had some sort of a problem in it, a flood or something like that. So there's no bicillin. Isn't that amazing? That just amazed me. So ODH has, they are going to roll out their triaging strategy. And yeah, at some point in time, you're going to have to switch to oral doxycycline. Because we're hoping this problem gets resolved. But you should probably be asking yourself, if you're giving somebody their 6th shot of bicillin, like.
Exactly, and especially when they're missed the time frame by just a few days.
Right.
How much, when is enough? And you hate giving the 6th or 7th shot, but
Right.
there's a shortage. But if they're a woman or pregnant,
Yeah, and that's what that should be triaged for. Yes, correct. And I think this would be, this is actually a great time to look at oral doxycycline, one of these follow-up studies to see, since we're pushing the oral doxycycline as the alternative, see how effective it is, see how many people break through. Because, it's hard to take pills twice a day for a week, especially if then they upset your stomach. It's difficult. So it'd be good to see how well that works. Any other questions at all for me? Yes.
Where I work at, we aren't primarily a healthcare provider, so we're only able to do rapid HIV screening and testing. What would be your recommendation for agencies like ours that don't have the capability of doing extensive screening for other STIs or syphilis in conjunction with our HIV screenings?
That is a great question. We're very hopeful that we'll be getting those rapid point of test kits, out and about in the next 2 years. I don't actually know the answer to that. I don't know. Does anybody else have any thoughts on that, about what we should be doing for agencies that can only perform part but not the full, the full screening menu, which is 3-site screening, HIV, and syphilis? I think doing something is better than doing nothing. Absolutely. Yes.
Well, hopefully they can refer to the local health departments. In Summit County, we do 3-site screening, so you're, you're welcome to send your clients to us. And we can follow up on them.
Yeah, and that is good. Except we also know, though, it's also a burden on patients not to be able to do it. Yeah. Yes.
I was just going to say, would it make sense then on the risk assessment, there's a question about if you know if you've had STI in the last 12 months, yes, no, or I don't know. And if it's a yes or an I don't know, then that would be a time for a referral, for sure, every time. If they don't know if they've had an STI, something like that, then send them over for referrals.
I think based upon what you're able to do, if you aren't able to perform those tests, absolutely.
Especially if they're like MSM or they obviously. Okay.
Absolutely.
And then remember, people who are screening positive for an STI or at risk for it, and this is my segue to Tommy. So, we also need to be protecting them and offering them PrEP, an option of PEP, and then I didn't even talk about DoxyPrep or DoxyPEP, which is another option, because I thought I tortured you guys enough with this talk. So we also need to be thinking about the full complement of ways we're going to protect people and acting on it. But yes, I realize a lot of agencies just don't have the ability to do that. And we don't have a very nimble public health system. But we struggled with this last monkeypox outbreak, getting vaccinations up. right? Thing is, up in Toledo, I get people that drive down from Detroit, and they had vaccine centers. Don't let them win. I'm just kidding. All right, any other questions?
There was one.
There's
question.
one.
Oh, yeah, one
one
chat,
from,
good, okay.
Online says, do we screen rectally for patients without direct anal exposure?
I mean, that is, so,
Can you repeat
Repeat the question.
ooh, yeah. The question is, should we screen people for the presence of anal or rectal STIs if they report no risk factors? And again, that's a great question. The answer was yes, you just do 3-site screening. But again, there's a new study coming out that says actually it's not cost effective to do that. And if you ask the patient or hand the patient screening materials and let them self-collect and therefore self-direct, you actually get you don't miss STIs. So, yes.
I would almost challenge that in the sense of what about the person who is engaging in receptive oral, in the sense of receiving oral copulation for anal stimulation, and that person has oral gonorrhea or chlamydia, can also be transmitted to that person's rectum in that process.
So this study was presented at ID Week 2 weeks ago, and it was in a session called Squabbles Amongst Friends, right? Was actually the name of the talk. So it's not, I mean, I'm just saying it's not, I have no clue what the real answer is. It's something we're actually looking at. Because, we got to be, as public health people, we've also got to be realistic. This stuff costs money, and we're also stewards of proper screening, right? So we must be cost effective and deliver an excellent product. We're not entirely sure sometimes what that is. Any other questions? Nope. Okay, thank you guys so much for having me here. Thank you.
Excellent. Well, pleasure to be here, everyone. Thank you for the introduction earlier. Once again, my name is Tommy Champas. I am a medical science liaison with Gilead Sciences on the HIV prevention side. Prior to coming over to Gilead, I was a clinical pharmacist with the University of Illinois in Chicago, which is where I'm from. And I was in the Ryan White clinics as well as a telehealth clinic caring for inmates living with HIV incarcerated in the 26 state prisons within Illinois. But like Dr. Duggan teed me up, this is a perfect transition going from syphilis to HIV prevention. And during the presentation, if there's questions, please feel free to ask during. You don't need to save them for the end, if that's okay with the okay, good. All right, disclaimer slide. These are non-promotional slides. Almost all of them do have a double dagger in the upper right section of the slide, indicating that data may be off-label or not FDA approved. And there are some slides taken kind of directly from the guidelines as well. And we are not endorsing, Gilead does not endorse the guidelines, we're just stating what they are. So we're going to start off with HIV incidence data. So when we look at the incidence of HIV, these are new diagnoses. In 2020, the rate per 100 person years was 100,000, was about 10.9 individuals in the U.S. You can see there were about 30,635 newly diagnosed individuals. In Ohio, the rate was 9 per 100,000. And in Summit County, it was actually 10, I believe. Breaking down those data, you can see the overwhelming majority of new infections were individuals who identified as being male. About 80%, females were 18%, trans women about 2%, trans men and other identities of each about less than 1%. On the right part of the slide, you look at the demographics based on age. And you see the largest age group that was impacted is about 25 to 34-year-olds. However, I'd also like to highlight the 13 to 24-year-olds, an adolescent population, if you will, is about 20% of individuals. And even individuals above the age of 55, about 10% were newly diagnosed with HIV. So it's not, this is not something that is just impacting one age group. It is kind of across the continuum, if you will. Looking at race and ethnicities, unfortunately, there's a disproportionate impact here. you see that the overwhelming majority of individuals are identifying as minorities, being Black or African American, as well as Hispanic and Latino, whereas whites account for about a quarter of the new diagnoses. This next slide breaks down the transmission category, or vulnerability or risk factor historically has been called. The darker or maroon red is in males, and then in the lighter or brighter red is females. So you see for males, the majority of individuals who've seroconverted with HIV, the risk or transmission category was male sexual, M to MSM, male to male sexual contact, whereas a heterosexual contact was the predominant risk for women. This does not preclude other potential ways and routes of transmission, such as injection drug use, and even you see heterosexual contact with male, and unfortunately, perinatal contact is still reported there. I guess kind of no surprise hearing the syphilis data that was just presented too. This slide is just looking at trans individuals. So of the about 1% or so, 2% of trans who are identified as being trans, you see the breakdown here by race or ethnicity. The left part of the graph is trans women, the middle is trans men, and then the right is additional gender identity. And you see, unfortunately, again, the disproportionate impact looking at minority populations. And African American Blacks are the purple graph, and that is kind of the biggest with trans women, additional gender. And then trans men is 28%. However, the largest impact there is white individuals who identify as being white. These data were presented at the CROI conference, the Conference for Retroviruses and Opportunistic Infections in 2022. And this was looking at a lifetime risk of an HIV diagnosis in the US. You can see male is on the left and female is in the middle graph, and on the right is kind of an overall general risk estimate of the United States. These numbers are a risk of 1 in. For example, a male is 1 in 76 lifetime risk. Just being a male, there's a 1 in 76 lifetime risk of acquiring HIV. If you're an Asian male, that risk is significantly lower at 1 in 187 compared to a Black male, where the risk is highest at 1 in 27 individuals. You see that's about a 6 times higher risk compared to a Caucasian or white male. When we look at the Black females, they have about a 1 in 75 risk, which is about almost a 12-fold increase compared to a white female. Nationwide, again, about a 1 in 120 risk for the general population, and in the state of Ohio, it was about 1 in 161. These data were compared to previous analyses in 2010 to 2014, and there was an improvement, if you will, meaning there was a decreased overall risk for the overall population, but again, I kind of sound like a broken record. There are disparities by sex, race, and ethnicity, as well as locations of residence, highlighting that the South here, the darker the color, the greater risk, and you see the South is kind of bright red, or dark red, I guess, and that has there's a greater risk of acquiring HIV in those states. How is HIV transmitted? Well, I'm sure you all know the biggest risk is blood-to-blood contact or sexual contact. So if there's a blood transfusion, per 10,000 exposures, 9,250 are estimated to seroconvert to HIV. Sharing needles with injection drug use is about 63 per 10,000. Percutaneous needle stick, if it is a deep enough stick, and the source has enough virus on it, about 23 per 10,000. When you look down in the middle part of this graph, looking at sexual risk, receptive anal intercourse or bottoming is about a 138 per 10,000. This is considered to be the highest, the largest vulnerable class when looking at sexual encounters. Compared to receptive or insertive oral sex is considered to be low, and even insertive penile vaginal intercourse is another low one at 4 per 10,000. Maybe some myths that is an opportunity to have opportunities to counsel patients with regards to our clients with biting or spitting, throwing bodily fluids. These are all negligible risks. Even sharing sex toys can be considered negligible as well. Now, one thing that's not accounted for on this, you'll notice, is the risk of STIs being associated with HIV. And Dr. Duggan highlighted that as well. So looking on the left part of this slide, you see that adolescents, just in general, the risk of HIV in adolescent population doubled just having an STI reported. In adolescent women, the HIV risk was nearly 5 times as high if they had 3 or more chlamydia episodes compared to women without any episode of chlamydia. When we look on the right part of the slide, you see that a higher risk MSM population with rectal STI diagnoses. Those who have anal sex are more susceptible to STIs due to thin lining of the rectal mucosa, as well as the synergistic effect, like Dr. Duggan mentioned. In particular, 1 in 15 MSM with rectal chlamydia or gonorrhea were diagnosed within a year from their STI diagnosis. They were also diagnosed with HIV. Looking at syphilis, 1 in 30 MSM with a syphilis diagnosis were additionally diagnosed with HIV in a year. So when you have those individuals in care for STI screening or testing, it's imperative to have these tests for HIV and maybe bring up the PrEP discussion too, and or PEP discussion, depending on the circumstance. This slide I think is really impactful too. This is historical data. You can see there's 8 different studies here on the left, and they were looking at the rectal gonorrhea incidence rate as well as an HIV incidence rate. So the green line on the graph on the right is kind of the predicted HIV incidence rate that we would see just based off CDC data. Each of those black lines indicate one of the data points from the 8 publications, and you can see there's a pretty strong correlation between rectal gonorrhea and MSM and HIV diagnoses. So again, it kind of maybe alarms going off, bells and whistles. If somebody comes in with a rectal gonorrhea diagnosis, make sure that they have an HIV screening. If they don't have one, offer it, and again, have the opportunity to discuss PrEP and PEP. And that leads us to that utilization. So I like this slide a lot, and I think you can see it highlights the differences between post-exposure prophylaxis or PEP and pre-exposure prophylaxis or PrEP. So PEP on the left in purple, and then PrEP on right in the blue. The dark colors, so the dark purple or the dark blue, indicates that somebody's on medication and they're essentially hopefully protected from acquiring HIV. So when we see that explosion, flower-looking thing, that's a potential exposure to HIV. So on the left with the PEP, you see the brighter purple means somebody was not on any type of antiretroviral coverage, but they have an exposure. Whether this be an occupational exposure like a needle stick, or having unprotected intercourse and knowing that the source patient was positive. Well, within 72 hours, if they start antiretroviral therapy, that's appropriate to initiate post-exposure prophylaxis or PEP. Let's say that same individual a few months later, or a couple weeks later, finishes their PEP course, they follow up, they're HIV negative, but then they have another exposure that they're unaware of. Well, they have no coverage, but then they have a third exposure that they want to go in for. They can take another PEP course, but unfortunately, because that middle exposure not having coverage may have compromised themselves and potentially seroconverted. Whereas you look at the right part of the slide with PrEP, and you see those same events, condom breaks, the condomless sex with partner of unknown status, and then somebody who's unsuppressed. Well, if they're on PrEP and they're taking their medication daily or coming in for their injections at appropriate intervals, they are then to be considered on therapy and should be protected from those events. Looking at the PrEP uptake, so we'll get into data now with kind of like the incidence data with HIV, but PrEP uptake in the US. So the first medication was approved in 2012. It was emtricitabine and tenofovir disoproxil fumarate. In 2012 to 2021, there was about 1.2 million individuals prescribed PrEP. The CDC identifies this at about only 25% of individuals who could benefit from being on PrEP. And you see the darker colors in green indicate the more PrEP usage. And you see there's a lot of white space throughout the US, and it doesn't mean that there are not HIV diagnoses there as well. Breaking this even further, this slide looks at PrEP usage as well as the PNR, or the PrEP to need ratio. Essentially, that's highlighting how many individuals are on PrEP compared to how many new HIV diagnoses are. The quote-unquote greatest region is the Northeast region. They have about 15 individuals on PrEP for every one new 15 individuals for one HIV diagnosis, compared to the South that has a lesser PNR, PrEP to need ratio, where they only have about 7 PrEP users for every new HIV diagnosis. There's a lot of potential opportunity there. The state of Ohio, I believe, is or not the state, I think, again, Summit County was a PrEP, about 9 users per every individual. So slightly better than the South and kind of slightly below the Midwest number there. You see on the right part of the slide here, the South accounts for more than half of all new HIV diagnoses, yet only about a third of PrEP users in 2019. So even though this is where a lot of the HIV diagnoses are occurring, there's not a lot of opportunities for PrEP there. These data are taken from the AIDS View. If you're unfamiliar with that, I highly recommend you check out that website. It's very user-friendly. You can get it to county-specific levels, city-specific levels, and it gets updated pretty frequently. This is another way of looking at this information. This is now from the CDC. Ending the epidemic, having the goal of 2030, we've got a lot of work to do to get there. Overall, again, about 25% of individuals who could benefit from being on PrEP were on PrEP in 2020, it was estimated. Unfortunately, you see the disparity in who those individuals were. About 2/3 of them identified as being white, less than 10% identified as being Black or African American, and about 16% Hispanic or Latino. This next slide looks very similar, but it's actually looking at the PrEP to need ratio. You see very similar numbers, about 26 with whites, and then lower ratios with Blacks and Hispanics. Again, just highlighting the disproportionate efforts, if you will, maybe, and education for these individuals where they might not know that PrEP is available. Maybe they don't know that it's an option for them. Maybe they think it's not an option for them because, and I know I've heard this, maybe commercials that doesn't look like me in a commercial. So it's important to have these conversations with the clients, with patients, that if they're vulnerable to acquiring HIV, these conversations need to be happening. These are data looking at men and women. 93% of all PrEP users in 2019 were men, and only 7% were women. And there were 7 male PrEP users for every new diagnosis, and you want that number to be as high as possible, and compared to only 2 female PrEP users per new HIV diagnosis in a female. And only 10% of women who could benefit from PrEP in 2019 were prescribed PrEP. Now this is taking 1 year back. These data are from 2018, and you see that the PNR, PrEP to need ratio, was about 3.5 times higher for men than women, indicating fewer PrEP users relative to the need for PrEP among women in the U.S. Some of the states with the lowest PNRs, you see Puerto Rico, Georgia, South Carolina, Mississippi, and Florida. In 2018 compared to 2019, women made up only 6% of PrEP users, despite representing 20% of the diagnoses. Compared to 2019, they made up about 7% of PrEP users, so a small increase. We're heading in the right direction, at least, I guess. Looking at young users of PrEP, keeping in mind the largest percentage of individuals was that 25 to 24 to 35 or so, 25 to 34, but those adolescents were also impacted at about 15-20%. So you see only about 15% of PrEP users were the age of 15 to 24, but they accounted for about 21% of new HIV diagnoses. So there's potential opportunities here to have those discussions. I understand this also brings a lot of other variables, such as the individual may still be on their parents' insurance and they don't want their parents to know. Maybe they're at school and the school's health department doesn't have a good PrEP program. We've heard a lot of these things being in the field, and they're there are ways to kind of get around some of these situations, but also it definitely provide realistic challenges to offering PrEP to these individuals as well. Looking at the transgender women population, this is kind of a cascade. I almost wish this would have been like a bar graph so you kind of could visualize it a little bit better. But 56% of trans women here in these 7 cities. So this was kind of an prevention intervention program at 7 U.S. cities done from 2019 to 2020. 56% of these individuals identified as being trans women were HIV negative. Fantastic. 92% of those 56% were aware of PrEP. 61% of those individuals participated in a PrEP, HIV prevention intervention, and unfortunately only 32% of those used PrEP. So the cascade would just be continuously decreasing, which unfortunately is kind of what we see with PrEP use, PrEP equity, PrEP need, as well as even HIV care cascade. We see people get diagnosed, linkage to care is lower, engaged in care, on ART, suppressed, and maintaining that. So there's just a lot of work that we can do in the public health sector, as well as all private, the healthcare field in general. We need to engage these individuals and keep them engaged if they are vulnerable to acquiring HIV. These data were presented at the World AIDS Conference in Brisbane, Australia this past summer, and it's looking at both a PrEP to need ratio as well as a PrEP to equity ratio on the right. So the two graphs in the middle identify that there has been an increase in PrEP to need ratios over time, which is great. Again, going from 2012 to 2021, we are seeing an improvement, which is what we want to see. Males in the red on the far graph on the left have the greatest PrEP to need ratio, and then females are improving but still far behind the male counterparts. Looking at different age groups in the middle graph, you see that there is an improvement across age groups, but the 35 to 44-year-olds have the highest PrEP to need ratio compared to the lowest at less than 25. And then on the right, they kind of looked at the PrEP to need ratio and compared it between the reference ranges, if you will. So they looked at PrEP equity, and are these groups equally being prescribed PrEP? And what we're finding is no. Women compared to men are being prescribed PrEP about 56 to 65% fewer times. The 13 to 24-year-olds, as well as the individuals above 55, are being prescribed PrEP compared to the 25 to 34 year, or the 35 to 44-year-olds. Excuse me. You see about 50% in the 13 to 24-year-old group less, to about 40% less in the greater than 55. So that's why I even highlighted that the quote-unquote older individuals above the age of 55, they're still sexually active, they still have opportunities to acquire HIV, and PrEP is not something that should be excluded from conversations with them in the healthcare setting. Now, looking at the guidelines, these were updated in 2021. These are taken directly from the CDC guidelines. They're very user-friendly, and they have a lot of these algorithms to really kind of help guide any potential clinical situation. So if you want to look here to see if somebody may identify from PrEP from a sexual acquisition, you can see if they had anal or vaginal sex in the past 6 months. If they didn't, you go all the way to the bottom right, and you can still discuss PrEP. And if individuals are requesting PrEP, kind of the general consensus is you can prescribe it as long as it's medically appropriate and they don't have any contraindications. But then you can see there's a lot of other groups here. Have they had a bacterial STI in the past month? Yes. If they're MSM, prescribe PrEP. If MSM and they've had gonorrhea, chlamydia, or syphilis, yes. If it wasn't one of those three, maybe have the discussion. If they have an HIV positive partner who with an unknown detectable viral load, or unknown viral load, have that discussion. Same thing if the viral load is detectable, maybe then you'd want to prescribe PrEP. So it's a pretty straightforward algorithm that you can use to help identify individuals who could benefit from PrEP. Another algorithm they've created was injection drug population. And you see here, if they've ever injected drugs in the past 6 months and they're sharing equipment, that's a yes, prescribe PrEP. And the other opportunities, you can have discussions. Now, something that I hear from a lot of clinicians is that the PWID population, or people who inject drugs, or PWUD, people who use drugs, they also have sex. So just because they fall in this PWID population, you could use this algorithm for them too. And sometimes when they are under the influence, maybe some of their sexual behaviors change or they become less safe. And again, that open discussion for the individuals is imperative to be happening. For oral PrEP, again, this is taken directly from the guidelines. These are recommendations for timing of lab tests. You can see all PrEP users should have an HIV test. It's recommended to have a renal function test. You'll see the three STIs, syphilis, gonorrhea, chlamydia. There's a lipid panel if individuals are on emtricitabine, tenofovir, alafenamide, and then Hep B and Hep C serologies. And you can see the quarterly updates or quarterly recommendations with every 3 months, 6, 12, and even if somebody stops PrEP. Looking at injectable PrEP, you see the recommendations are here. You'll notice that some of them fell off, like the Hep B and Hep C. Again, it's not in the guidelines. However, talking to a lot of clinicians, they feel very strongly that if they have the individual engaged in care, they are going to be checking them for as many things as they can. So it's obviously up to the clinical situation for the individual, but you may want to consider those. Yes, there's a question?
Yeah, why no Hep A?
Why no Hep A? That's a fantastic question. To be honest, I don't know. I think the prevalence is pretty low, and Hep A is often self-limiting too. But I don't know exactly, but that is a good question. It would be a great opportunity to vaccinate if they are negative. Okay.
We have an outbreak right before COVID.
There was an outbreak before COVID here? Okay. So yeah, definitely. So again, if you have them engaged in care, check them for everything if you feel it's appropriate. The last few slides are highlighting sexual health discussions. So this may be something that can be seen as difficult for providers, clinicians to have. It may also be difficult for patients to have these discussions with providers, especially maybe if that trust isn't there. But it's imperative to have these because having these discussions opens the door to better care for the individual. You're going to gain a better overall picture for their health. You can discuss topics or a topic that maybe they're not comfortable with, and this could even include mental health and anxiety. A lot of times there can be sexual trauma or other mental health and anxious characteristics associated with this. Counseling and sharing information about behaviors can increase education about STIs and HIV exposure, as well as just exposure to the STIs in general. And then because of all this discussion, you may be able to screen more appropriately and potentially protect the patient from acquiring something and or treating something if it's appropriate. Looking at kind of a status neutral approach, these sexual conversations can help individuals who are living with HIV as well as individuals who could benefit from PrEP. Just by sharing their status if they're positive, having that U equals U or undetectable equals untransmissible conversation. Pleasure and STI prevention goes both ways. And even starting PrEP in those individuals who may benefit if they're having unprotected sex and or they might just want to have be offered PrEP after having these sexual health discussions. And lastly, one of the approaches that's recommended, the CDC has 5 Ps, but in this slide, if you will, there's 8 Ps. And these are things that individuals could talk about with their patients. Preferences of sex, partners, practices, what type of pleasure they appreciate. What are they doing to protect themselves from STIs? Do they know that they need to be doing this? A lot of times maybe people think just because they're on PrEP, they're protected from STIs. Or because they're on HIV therapy, that they're protected from STIs. And we know that's not the case, but maybe there's some education opportunities there. Maybe a past history of STIs. Somebody doesn't disclose maybe that they had a syphilis treatment. And a lot of times they might not know what that was, but if you say it was a pretty painful shot of like a milky substance in your rear, they're like, oh yeah, I had a couple of those, or I had 3 of those, whatever it may be. Pregnancy considerations. Does somebody want to become pregnant? Maybe they don't. That opens up another discussion for potential contraception discussions, and even a power dynamic and partner violence. Again, unfortunately, like I said, there could be anxiety associated with sex. But these are all things that will just help the patient feel more empowered and have a greater relationship with providers as well. And the last couple slides are resources in general for HIV PrEP. And I'm happy to answer any other questions or receive any comments and discussion from the group. I think this is it. Yeah. Thank you. Is there a question? Nope. Yes, another.
I have 2 questions.
Okay.
So if somebody says they have a partner who's in the undetectable category, do they not get PrEP, or should they?
So the question was, if somebody has a partner who's living with HIV and they're in the undetectable category, should the HIV negative individual receive PrEP or not receive PrEP? That's really just the preference of the couple, preference of the individual who's negative. When I was in clinic, I had a lot of partners or couples like that. And more often than not, I felt like the negative individual also wanted to be on PrEP. I remember from a few times, they felt like by them taking something orally and their partner taking something orally, they were doing something together. And then I also kind of heard the opposite spectrum where partners maybe didn't trust each other, or they were identified as having an open relationship and they wanted to make sure that they were just protecting themselves a little more.
And my other question was, what's the minimum age to get PrEP?
What is the minimum age to get PrEP? I'm blanking. Is it 12 or 13?
Based on weight.
It is based on weight, yes. I'm sorry, thank you. 77 kilograms, thank you. Pounds, yeah, kilograms. 77 pounds, thank you, Karen. Yeah, 77 kilos would be, a lot of people wouldn't be on PrEP, I guess, yeah. It is based on weight, so 77 pounds for oral. Any other questions? No questions online. All right. Well, thank you all so much. I think the slides were sent out. My contact is there. I'm happy to be a resource anytime. Please don't hesitate to ask any question and reach out.
We did just get a question.
Okay.
Is there a potential of harm for patients without HIV to take PrEP, and if so, what about long-term effects?
Is there a potential harm for patients without HIV to take PrEP, and what are long-term effects?
Yeah, and if so, what are long-term effects?
Realistically, I mean, I guess every medication has the potential to have toxicities over time, but the PrEP medications are safe and efficacious. They wouldn't be FDA approved if they were not. And that's part of the reason why it's recommended to have those routine follow-ups and have the routine screening for labs as well.
And just to clarify, PrEP is pre-exposure, so these would be for people without.
Yes, PrEP being pre-exposure, so those individuals do have without or living without HIV, yes. Thank you all.
And I would just like to take the opportunity to thank everyone attending our live Zoom call and participating in this educational summit and all the information on HIV and syphilis. Thank you.